Hello, good afternoon or evening or morning or whatever time you're watching this. I am Christy Corsi, the Executive Director of Breastfeed Atlanta, and this is a staff training video for staff use only, and today we are talking about gap exceptions for out-of-network insurance patients. So I'm going to start by removing that. I don't need that right now. So I'll start with talking about why we do this, because someone could easily argue that billing out-of-network insurance is a complicated, lengthy process. Why are you going through all this trouble? And the reason, put very simply, is that it's very important. One of our core values is accessibility. I created, and you guys all helped me build this company with a goal of making lactation care affordable and accessible to everyone. And ironically, when I was a young mother with my children now 20 years ago, I could not have afforded the care that I now provide. And that's wrong, and that sucks. So we're going to do everything we can to make this care accessible to people. And the reason is that inability to access expert care should never be a reason that breastfeeding doesn't work. We know there are enough legitimate reasons that breastfeeding sometimes doesn't work, but not having a good lactation consultant should never be one of those. And so one of the best ways that we can open that door to access for as many families as possible is to build insurance. We are working very hard to be in network with as many insurance companies as possible. As you guys probably know, I've done a lot of advocacy work at the state level. I've spent time in the Capitol talking with insurance companies on our state Medicaid board and doing everything I can to make us able to be in network with insurance companies. But until then, this is what we're working with. So right now, Breastfeed Atlanta is in network with Medicaid, including all Medicaid CMOs. So that means CareSource, AmeriGroup, WellCare, and Peach State. We're also in network with Aetna. We have a signed contract with Humana. That'll be active on October 1st, 2019, and we are in process with Cigna. Jessica, our insurance coordinator, is working hard with all the other carriers to make that happen. Breastfeed Atlanta is in a unique situation in that we have some nurse practitioners on board as well as our medical director who are kind of opening that door to insurance panels, so we're able to get in network in a way that other insurance companies aren't. So that's important to remember, that we're in like a very different situation than other lactation consultants. But right now, that's who we're in network with. So this specific process and workflow does not apply to in-network insurance or people without insurance. This is only for people that have insurance that is not in network for Breastfeed Atlanta. I'm going to give you guys some vocabulary words, and then we're going to talk through our workflow and discuss where everybody fits into it. And I think the vocabulary words are going to be about 90% of this. And I'm adjusting the other side of my screen where I have my notes. Bear with me. First vocabulary word is in-network insurance. That means that Breastfeed Atlanta has an active contract with the patient's insurance company, and our services are a covered benefit for that patient. Usually, that means we don't collect any payment for the visit. Every now and then, under certain situations, we might for certain types of newborn clinic visits, lab visits, that kind of stuff. Out-of-network insurance is the next vocabulary word, and that means the exact opposite of in-network insurance. That means we don't have a contract, and so it'll be very difficult for us to get paid without a gap exception, which is kind of down the list. We'll talk about that in a second. Deposit is money that a patient pays to us with a credit card at the time of scheduling, and we just kind of hold on to that while we're seeing if the insurance company will pay or not. When the insurance company pays and they pay appropriately, we refund that deposit to the patient. It's very important that when you're talking to the patient, you ask them to pay a deposit, not a fee, and not, payment for the visit, but a true deposit. It's very important that they understand that, because what we don't want people to think is that we're taking payment for the visit and then also asking the insurance company to pay, because that's kind of shady, and we don't do that. The next word is Affordable Care Act. This is synonymous with, some people call it the ACA or Obamacare. This is a law that was passed in our country in 2010, and it changed a lot of things related to healthcare. They did away with pre-existing conditions, which is particularly pertinent to our patients who are born prematurely, or people who are pregnant when they first get their insurance. The Affordable Care Act also has a huge provision for preventive care, which is what particularly applies to us, because lactation care and coverage is mandated as a mandatory preventive health benefit under the Affordable Care Act. Breast pumps too. An exempt plan, that's another vocabulary word, is a insurance plan that is exempt from ACA rules. So these are plans that do not have to play according to the ACA rules. That would include any government payer, so Medicaid, Medicare, TRICARE, VA, Indian Health Services. None of those have to pay. And then this also gets kind of tricky because, Jessica, correct me if I'm wrong, but I'm pretty sure that Blue Cross Blue Shield federal employee benefit that like CDC and other federal employees have, that is a government payer. They don't have to play by the rules either. And stepping outside my professional role and getting like a tiny bit political, I just find it ironic in the most bizarre way possible that the government doesn't have to play by government mandated rules. WTF. Anyway, just because it's a government payer, it doesn't mean that they won't pay for lactation services. Sometimes they will. It just means they don't have to. Other types of exempt plans would be grandfather plans. There are very few of these around, but that would be a plan that existed before the Affordable Care Act was enacted and has had zero changes or modifications to it since then. There were a lot of these in the years immediately following the enactment of the Affordable Care Act. I haven't seen one in quite some time though. What we do have a lot of in the metro Atlanta area are self-funded or self-insured plans. So this is when an employer is providing and underwriting the insurance health benefit themselves. Examples would be like Piedmont Health System and Wellstar also do this because they are large healthcare entities, and they have their own doctors and hospitals and facilities. They can provide their own network, and it is cheaper for them to do that than to have an outside insurer provide that. Now sometimes, and actually indeed they do have one of the major insurance carriers administrates their plan, but they don't underwrite it and they don't actually pay for the care. So you will see that it says Aetna or Blue Cross Blue Shield on it, or hold on a second. Babe. I am right in the middle of doing a video. Is it urgent or can I call you back? Put them through to extension 6 until, so you press pound, so go back to the call, press pound on the phone, and then wait for the prompts, and it's going to say to transfer to an extension, I think press 1, and then it's going to ask you what extension, and then you'll press 6, and just listen to it. It tells you what to do. Thank you. All apologies. That was a work-related call. Anyway, so exempt plans are self-funded or self-insured. Piedmont and Wellstar are examples. They may still be administrated by a large national carrier like Aetna or what have you. And you will know that it's one of those plans because it'll say self-funded or self-insured or something similar to that on the card. Again, just because they are exempt and they don't have to pay for lactation care doesn't mean that they won't. Sometimes they will. Non-exempt plans are everybody else. So most plans are non-exempt under the ACA, most private plans. In Georgia, that's going to be about 50% of our families have private insurance and 50% have Medicaid. But of the 50% that are privately insured, most of them are going to have a non-exempt plan. Marketplace plans, we don't see very many of these either, but those are plans that are bought on healthcare.gov. The Affordable Care Act actually established these marketplaces. Sometimes, depending on the state's level of participation in the law, they may have their own healthcare marketplace. Georgia does not. We use the federal one. So people are eligible to purchase these plans if they do not have an employer-funded plan and they're not eligible for Medicaid. Sometimes they are eligible for a subsidy, though. If their income level is above the threshold for Medicaid, but below some other threshold, I don't exactly know what it is, then they may be eligible for a subsidy there. But those plans are non-exempt. That is a legit Obamacare plan, and they have to pay for lactation care. A super bill is a document that is basically a glorified receipt. It is a very, very detailed and itemized receipt. So it's going to have, and it's only for healthcare in this context, so it's going to have details about the provider, NPI, tax ID, address, so forth and so on. It's going to have the patient demographic information, and then it's going to have the diagnosis codes, the procedure codes, and any money that the patient paid for those services. And that document is used when a patient is applying for their own reimbursement. So healthcare providers like Breastfeed Atlanta and others, we do not use super bills to file insurance claims. We use something called a Form 1500, which we don't even need to discuss. But just know that when we are giving a super bill, that is because we're not filing for reimbursement, but the patient is. And we'll talk about specific instances why that would happen. So that would be for a out-of-network exempt plan. Also, you have certain instances where a patient may have like a health share, like Good Samaritan or Christian Health Services, which actually requires the patient to pay themselves and then apply for reimbursement. They don't pay providers. They will only pay their members. And then the big thing that we're talking about today is the gap exception. So how do we get to this place, and what is a gap exception? So reviewing a little bit, the Affordable Care Act says that insurance companies, unless they are an exempt plan, which most of them are not, have to pay for lactation care and coverage. The trick is that insurance companies can require that care come from an in-network provider. And as of this recording, the gross majority of private pay insurance companies do not contract directly with lactation consultants. So what happens is when the patient tries to access their lactation benefit, they will be told by their insurance company to any myriad of things. They'll be told to call the hospital where they deliver, and in Metro Atlanta and indeed across the whole country, most hospitals are not providing outpatient lactation care, so that's not appropriate and not accessible to them. They are also told to call their OB and their pediatrician, which is highly ironic because the OBs and the pediatricians actually refer to us and other lactation consultants, and OBs and pediatricians are not in a place practically or with regard to their knowledge and their resources of time to provide a lactation consult, so they don't do it. Sometimes patients are told to call WIC, which is also inappropriate because WIC does not provide clinical lactation care. WIC provides nutrition assistance and education. So long story short, there are no in-network lactation consultants for most private pay, non-exempt, out-of-network plans. So many times the patient just ends up either without care or paying for it herself if she can. This is actually illegal, and the insurance companies know it, but for the most part, they've been getting away with it, and so they keep doing it. There have been several class action lawsuits against United Healthcare and Anthem that were successful about this. And sure enough, Anthem seems to approve our gap exceptions left, right, and center. They give us a little bit of difficulty, but they do it. And then recently, Cigna was in the national news and got a ton of bad PR about this. So they have been more cooperative lately too. So the gap exception, back to that. Gap exception is when an insurance company agrees to pay an out-of-network provider as an in-network provider for a very specific instance of care because they don't have an existing in-network provider that can provide that care to the patient. Synonyms for this include in for out. That's what Blue Cross Blue Shield calls it. Sometimes they may call it a geographical exception. Sometimes they refer to it to prior authorization for a non-network. But if you say gap exception, everybody's going to know what you're talking about. And so that is what we do when a patient comes to us and they have a non-exempt out-of-network plan. Most of those are going to be Cigna, United Healthcare, and some form of Anthem or Blue, which could be Blue Cross Blue Shield, or just Blue Cross, or just Blue Shield, or just Blue Cross of Illinois. If it has blue in it, then it's one of those, or Anthem. There are several others. Side note, we cannot get gap exceptions for TRICARE, if you see that, because TRICARE is a government payer. They don't have to play by the ACA rules, and they choose not to. You also cannot get it for Kaiser, because Kaiser has their own network, and so they don't have a reason to do this. Kaiser is actually one of the good guys in this fight. So, now that hopefully we understand, have a foundational knowledge and know what we're talking about and why we're doing this, I'm going to talk to you about how we actually do it. If you are not a member of our billing team, there has been like a ton of activity going on kind of behind the scenes and under the surface that you haven't seen. And part of the goal of this video and this training is to kind of bring you into that and let you know what's going on so that you feel confident discussing it with patients. And then we're actually going to ask you to help us a little bit in that, and I think it's going to work out really well for everybody. So I'm going to walk you through this process, and again, nobody has to be taking notes or memorizing this. I am happy to help you, so is Jessica and Dara. I've also got like a nice, neat little list of notes that I'm sending along with this video. So just kind of listen to this, and then I think the first time we actually do it with a patient is when it's really going to sink in for you. Okay. So for patients who have out-of-network insurance that is non-exempt from the ACA, this is what happens. The patient schedules a visit, could be on the phone, online, in person, and their insurance information is collected somehow or another. That is step one. Step two is somebody starts the gap exception workflow. You guys are not responsible for knowing what that workflow is. You just need to know that it's happening. So there is a staff member on duty every weekday who is constantly looking for new patients who need gap exceptions. Most of the time it's going to be Dara, but sometimes it is me or it is Jessica, depending on the situation and how busy we are and what our staffing looks like. So usually Dara will start the gap exception workflow. So what that involves is usually her kind of aggregating the patient's insurance information, and then we call the insurance company. And you wait on hold anywhere from 45 to 50 minutes, and then you talk to them for about 5 to 10 minutes. They're going to ask you all the identifying and demographic information for the patient. They will ask us for diagnosis codes, procedure codes, and then they're going to ask us why we're asking for this, which is geographical is always our reason because you don't have any in-network people. And then we're going to ask them for 15 visits, and we're going to ask them for 6 months of coverage for this. And if we are lucky, it's approved immediately. Sometimes they will say, yep, you're approved. Here is your reference number. More often than not, we are put off somehow or another. They'll say they have to elevate this to a clinical nurse specialist or to the medical director, or they'll say we need clinicals. And so whatever they ask for, we'll immediately start sending it to them and working through that process, going through the steps until we either get an approval from the insurance company or until we have a denial and we have exhausted our ability to appeal it. Frequently when they give us a denial, it is not just or accurate. They will frequently give us denials that say, oh, the patient can go to Grady and get lactation care. Or, and this is true, they can go to the 6th floor waiting room of the Kennestone Outpatient Pavilion, which is where, guys, people wait to have their mammograms done. That is where Cigna says that people can go to get lactation care. I surmise that they are just kind of putting any kind of BS on paper to be able to deny it, thinking that people won't appeal it, but they don't know about us. We are not playing. We will call them on their BS every time. So we file appeals for that. You don't have to participate in that. Just know that it's going on behind the scenes. And when you're talking to patients, just know that we are fighting tooth and nail and doing every single thing we can to get this paid. We are taking notes and constantly refining our processes, and we're getting really good at it. And it's going to be even better after this. That is step 2. Dara or one of us does that workflow. Once the workflow is completed, it is handed off to our billing coordinator, Jessica. And if you guys haven't met Jessica yet, reach out to her. She is super sweet, and on top of that, she's just brilliant. We are very, very fortunate to have a billing coordinator who is highly experienced, specifically in Medicaid and pediatric billing, and she is also a certified lactation educator, y'all. And she's in process for becoming an IBCLC. That makes her very unique and shiny and unicorny and very beloved by us because she understands that she is setting the stage for her future profession. So this is personal to her as a mother. It's very important to her for her professional future. So Jessica is like on her game, and she has been amazing for us. And she actually prompted me to make this video and train you guys because she was like, hey, I think I see a way that we can improve here. So once Jessica has it, and once it is complete and has all the right stuff in it, then she is going to start talking to the patient about it, and she's going to start talking to our clinical staff members about it. So that is step 4, adjusting my notes. So in the event that the gap is denied and we have exhausted our appeals, she's going to talk to the lactation consultant and the patient, probably in an email, and she's going to say, hey, this is denied. We tried this, this, and this to get it covered, and we just can't. I'm so sorry. It's probably not going to be paid. We're not planning to file right now, but would you like a super bill so that you can apply on your own, or you could, maybe this could be a tax write-off or something like that for you. And if the patient accepts, then we will send them the super bill. If they're really upset and they want us to file anyway, then we will. And what will more than likely happen is that whatever we bill will be applied to the patient's out-of-network deductible. That is for denials. For approvals, which most of them are approved, for approvals, this is what we do. Jessica is again going to get in touch with the clinical staff member and with the patient and say, hey, your gap was approved for this many visits between these dates. And then she's going to say to the lactation consultant, is this appropriate and is this sufficient for the patient's needs? So she's going to basically say, do I need to go back right now and fix something, or are we okay for a little while? Sometimes certain things happen where they will approve lots of classes but not lots of visits, or lots of visits but not lots of classes, or weird stuff happens. So she's going to ask you if that's appropriate, and if you say it's not, she's immediately going to act on it and get in touch with Dara and get more visits or more dates or something like that approved. If you say that it's appropriate, then she's going to say, okay, and we're going to just keep it moving. What will happen at that time is the patient's benefits are going to be documented in the client notes section, and Jessica is going to ask both the clinical staff member and the patient to let us know when we are approaching the end of the patient's approved benefits. So for example, if the patient's benefits run out at the end of September, we're going to ask you to let us know, the 3rd week of December, hey, she expires in a month and she's still getting care with us and she's going to need ongoing care. Can you please apply for more visits? We're also going to set a calendar reminder for that. So that's not all on you, but if you notice it, let us know. Likewise, if you are scheduling a patient's fourth visit and you know she only has 6, and you'll know that because it's going to be there in the client notes on acuity, when you're scheduling that, reach out to Jessica and say, hey, she's almost out of visits and she's going to need more. Please reapply. And she will. And we will start the whole process over again and keep everybody updated as we're working through it. So that's the gist of it, is we're going to be communicating with you and the patient a lot and asking for your feedback and your participation and your input so that we can coordinate those benefits. I think this will be beneficial for the lactation consultant because it'll kind of bring you into knowing what's going on so you're not shooting in the dark, because you're the one that actually spends face time with the patient. Even though me and Jessica and Dara are working through this process and we know what's going on with it, we're not the one that gets asked the questions. It's you guys. So I think it'll help you feel more confident and a little more empowered to talk to the patients about their insurance benefits. And then it's going to benefit the patient because they're going to get better coverage, and you're going to save us steps and help us be proactive and be kind of ahead of the game rather than trying to keep up. That is the basic process. I'd like to highlight a few things that we need very specifically from clinical staff people and then from just everybody. Clinical staff member, by the way, can be anybody that's involved in the patient's direct care. So interns, lactation consultants, nurse practitioners, any of those people. I need you to check your email every single day that you work and respond promptly. And it does not have to be a highly polished formal response. Jessica's going to be asking you stuff like, this patient is approved for 3 visits. Is that enough or does she need more? And then you can respond and say, no, she quit breastfeeding. She's fine. Don't apply for more. Or, yeah, we're really going to work at this, so she's going to need a lot of visits. The being prompt is more important than being formal or, highly eloquent in your response. That is one thing. Check your email, respond promptly. Sometimes these things are time sensitive. Sometimes they only give us 24 hours to respond. So if me or Jessica start blowing up your phone, that's why. And we'll try to blow up your email and blow up your home base so that we're not bothering you on your personal time, hopefully. The next thing is for Christy, Tracy, and Heather. We need to be monitoring our site-specific emails and then route or respond to those emails as is appropriate. So if Jessica doesn't know which lactation consultant is seeing the patient, she's just going to send it to the correct site. So if it's Midtown, it's going to go to midtown@breastfeedatlanta.llc.com and so forth and so on. So we all kind of need to be on top of that. And then also from clinical staff members, when you are scheduling a follow-up or even when you're seeing that patient for the first time, check the patient's client notes in acuity and communicate what it says there to the patient because they may not have heard it yet. They may not have checked their email. So read it and tell them, oh, it says that we've applied for your gap exception, but we haven't heard anything back. Or you're approved for 8 visits or whatever it is, and communicate that to them. And then if you notice at that time that what is in acuity as the patient's approved visits is not appropriate to what they need, immediately inform Jessica so that she can start working on it. That is from like the clinical side. That's what we need. The next side is for anybody that schedules appointments, whether it is on the phone, in person. Sometimes we text people and email to schedule appointments. So anybody that schedules an appointment for a patient, I need you to do this. 1, for initial appointments, I need you to inform them and give them a basic summary about our gap approvals. You don't need to review this whole video with them and do all the details, but they need to know that we're going to apply for a gap exception. They may be getting some mail and they're going to be, receive communication from us about it. So you'll say something like, your insurance company does not have an in-network provider in our area, but we're going to apply for a gap exception to see if we can get them to pay for it. It could take a day or it could take a month to get approval on that or to get an answer. So what we're going to do is ask you to pay the $75 deposit, and that is refundable if we can get your insurance company to pay. Just as simple as that. And then we need you to get their insurance information as quickly as possible. That will allow us more time to be able to get the gap exception. They will not backdate these. So if we can't apply for the gap exception on the same day or before the day that they are seen, that visit will not be covered. Dara works every day from about 8 a.m. to 1 or 2 in the afternoon. So especially for your same day appointments, see if you can get them to do it over the phone or if you can get them to agree to do it right away. I understand that sometimes the phone is ringing off the hook, or the person calling may be holding a crying baby and she may not have a few minutes to do that with us, but try to impress upon them like a slight sense of urgency and let them know that it's for them. It's not for us because we already have our $75. Don't say that, but it's for them so we can get this covered for them. So you'll say something like, we want to start working on your insurance case right away, so please click the link in your email, fill out that form, and we will immediately get started. And if you say it like that, I think that they'll understand that we're trying to help them, not just collect superfluous information. That is what I need you to do for initial appointments. For follow-ups, I need you to review the client notes section in Acuity and proceed accordingly. So if it says the gap is denied, then charge them the deposit and tell them that Jessica will get them a super bill. If their gap is approved and they have plenty of visits noted, then you'll say, okay, I'm using the coupon code. You have no deposit due today. You have 4 visits left until we have to apply for more. And if you notice that they only have 1 or 2 visits left, or that they expire next week, go ahead and alert Jessica and let the patient know that you're doing that. Say, hey, you've only got 2 visits left, but we're going to go ahead and apply for more, and we'll let you know what happens. So that is basically it. It's just a whole lot of communication across the continuum of all the jobs that are performed in our company to serve patients. So I don't think there's anything proactively that you have to go out and study or go out and do. It's more about just knowing that our billing staff is going to request information and communication from you, and then just being as prompt as possible in your responses is what will help us the most. I'm really looking forward to this new process where it's kind of refined and streamlined for us, and also it improves our engagement with our patients, kind of helps us manage their expectations, and hopefully will help our clinical staff members feel more comfortable discussing insurance benefits with patients. I've gone over the time that I really wanted to do this in 30 minutes, but it's 32. Hope everybody has a wonderful day, and please reach out to me with your questions. Bye.